Good morning, everyone. There's nothing to disclose. As Dr. Alok said that there is a term called as the cytokine storm. This is nothing but this is an exaggerated host immune response, which is secondary to the viral infection to the epithelial cell of the alveoli. So once the virus has infected the epithelial cell of alveoli, it releases the genetic material which actually invite the macrophages and monocytes to release the inflammatory markers. One of the main inflammatory markers is interleukin 6, and we actually, by the tocilizumab, hit the interleukin 6 pathways. This drug is not a new drug. This is interleukin 6 receptor blocker, and this is recombinant humanized monoclonal antibodies, and it has been used from many decades as an immunosuppressive therapy for the rheumatoid arthritis, systemic lupus, idiopathic arthritis, and other autoimmune diseases. So this is a current practice. This is actually the off-label use of tocilizumab in the COVID pneumonia cytokine storm, and this practice has also been used by in our SGPGI guidelines also. So once 3 of these conditions met, we use the tocilizumab when there is an interleukin 6 is increased 50 to 100 times than the normal. There is a worsening trend of inflammatory marker like the CRP, ferritin, LDH, and there is a deterioration in the clinical condition of the ARDS and worsening of the PF ratio. Then we use tocilizumab in our patients. So dose which we use is 8 milligram per kg body weight. Maximum dose is 800 milligram at one time, which is dissolved in 100 ml of normal saline and given over the span of 1 hour. Second dose can be repeated if we think that there is a benefit of giving the second dose. There are many contraindications of tocilizumab. These are the patients living with HIV, active infections, high serum procalcitonin, which is a marker of sepsis, active tuberculosis or tuberculosis in the recent past, active hepatitis, neutropenia, thrombocytopenia, hepatic and renal impairment, chronic steroid therapy, pregnancy and nursing mother, and very small child also. What we bother about the adverse effect, the most important adverse effect which bother about the systemic or secondary infection following the tocilizumab therapy. There are some soft tissue and skin infection, and following the tocilizumab therapy, we find the abnormal LFTs, hypercholesterolemia, neutropenia, and since this is a monoclonal antibodies, so chances of anaphylaxis is very high. So now amalgate some of the literatures to rationalize our treatment. So these are the few initial case report which has mixed results. Later on, the case series has been published about the use of tocilizumab for the COVID pneumonia. But the retrospective trial, which has come up based upon the cases done between the May to August, and they all retrospective trial has published in the September to October, and most of them have shown that there is a positive result by tocilizumab in reference to the decreasing the mortality as well as decreasing the chances of mechanical ventilations. Whereas a few of this retrospective trial has shown that there is a risk of infection following the tocilizumab therapy. The meta-analysis which was done on the basis of analysis of these all retrospective trials had also shown that when tocilizumab group has been compared with the standard treatment group, they found there is a decreased incidence of admission to ICUs, need of intubation and ventilation, and mortality benefit in the tocilizumab group. But so far, before that, there was no randomized control trial. So first randomized control trial was published in JAMA in October 20, almost 1 month back, and the main objective was to compare its tocilizumab effect in preventing the clinical worsening of the patient, hospitalized patients with the COVID pneumonia, and they include those patients who have a COVID pneumonia with the respiratory distress, respiratory failure of moderate respiratory failure, like PF ratios between 200 to 300, with the symptom of fever and high inflammatory marker count. They have excluded those patients who have any kind of ventilation like invasive and non-invasive, and they are admitted in the ICUs. Their primary endpoint was that within 14 days, is there any admission to ICU because of mechanical ventilation, death by any cause, and clinical worsening in the form of when the PF ratio has decreased less than 150. And what they found there is no difference between the two groups. And also in the form of the primary outcome, they have not found any benefit effect of the tocilizumab over the standard treatment in the form of clinical worsening within 14 days. 30 days mortality was also same as in the two groups, and intubation and mechanical ventilation were also same. So they have concluded that there is no benefit of tocilizumab therapy on the disease progression as observed as compared to the standard care in the patients with a moderate COVID pneumonias. So later on, there is a two more trial has been published. One is on NMJ and one is in JAMA, and two more robust trial is also ongoing, and their interim result has been published. So I have make a tabulated form, and just to show that all these four randomized control trials are randomized, except the Corimino, all other have a blinded and placebo control, which is a not blinded, and it has not used any placebo. All have a multi-site studies. Most of them are in the multinational trial also. As far as tocilizumab therapy was used in most of the cases in almost half of the patients. Most of the trial has used the tocilizumab in the severe cases, except the Covecta trial, which has also used the tocilizumab in the ventilated and critically ill patients. The regime, what they use is the Back-Bay trial has used the only single dose. Rest of the trial has used one dose followed by the option of second dose also. What is the difference in the outcome? So outcome in the Back-Bay trial, there was no benefit by the tocilizumab on the death and mechanical ventilations, whereas in the Corimino, there is two different outcomes, like WHO score has not improved, whereas the survival has some effect. In the Covecta, there is no effect on the outcome of the patients with the tocilizumab therapy, whereas the Impacta has shown the death and benefit on the death and mortality. Just it is very surprised to see that on the 20th day and 30-day mortality, none of this RCT has shown any benefit of tocilizumab over the standard care. So I can conclude that in several retrospective and observational studies has shown that there is a potential mortality and clinical benefit by the tocilizumab in the critically ill patients with the pneumonia, but RCT says something different. That 2 RCT out of 5 has shown the benefit, 3 has not shown any benefit, and we are still waiting for the final result of Covecta, Impacta, and other robust trial to come to say or to form any concrete recommendation about its efficacy and optimum regime, whether the 1 dose or the 2 dose regime. So these are my recommendation. Thank you. And presently we are using the tocilizumab in therapy in our institute. With our experience, we can say that therapy has only benefit when we have used early in the phase of the COVID pneumonia. That is the only conclusion we can say with our experience.